Good afternoon. Welcome to session 5 of this adolescent and welcome to session 5, Alive and Thriving, Treatment, Care and Support to Adolescents Living with HIV. Sadie, can you hear me? Are you online with us? So we may be having a technical hitch. My name is Izukanji Sikazwe with the Center for Infectious Disease Research in Zambia, here in Lusaka, Zambia. And I say a warm welcome to everybody from a rainy Lusaka. We've had the first major storms for Lusaka. So my co-presenter is Sadie, and she'll be coming through to give us a little bit of background about our session. So we warmly welcome everybody, and we hope that you are introducing yourselves in the chat. I would like to know who's joining us. Sadie? All right, looks like we're having a bit of a technical hitch with Sadie, and we'll give her a little bit of time to join us. So, and once she joins us, she'll be able to introduce herself. She's Sadie Brown from South Africa. To keep us going and to give chance to others to join this session, we'll spend the next couple of minutes tracking the introductions through the chat boxes. So please do put in where you're joining the meeting from, whether you're joining it with a group of friends. And as I say that, I'd like to give a shout out to all the adolescents and young people joining this meeting from the CIDR's office, from the CIDR's hub. And this group is led by Zoe. Thank you, Zoe, for such a remarkable job in getting all the adolescents and young people to join us at our CIDR's office. Please also remember to take a selfie of yourself during these sessions and tag us on your social media platforms. Please use the hashtags that have been circulated via email. We're really looking forward to tracking the attendance on the various social media platforms that are associated with this workshop. Hi, Shanaz. I see Shanaz from Mandaria in Johannesburg joining us. Happy to have you here, Shanaz. I see my fellow friends from Zimbabwe, Taya Radzwa. I hope I pronounced that correctly. Welcome, happy to have you here with us. Hi, Charlene. Again, don't forget to take your selfies with your friends. Use the tag links that have been shared with you. Post them on all your social media handles, and don't forget to tag us, and we'll track you that way as well. Hi, Jamal. Hi, Maria. Lots and lots of people joining in now. Welcome, welcome. And I see a colleague, Dr. Jinwala Rokaya, right here from Lusaka. Pleasure to have you, Dr. Jinwala. Hi, Abby. And big greetings to everybody else that's joining us. Unfortunately, my co-presenter, who really should be leading this session with me, Sadie, has had internet connectivity problems. So as soon as she comes on, we'll have her engage with us and give us a little bit about her background. So we're going to be getting ready in the next few seconds to have our keynote presentation. We're really looking forward to this and to hearing from Dr. Foster.
Thank you very much to Sadie and Zuzu for their kind invitation. My role today is to give a brief overview of aspects of adolescent care that we're going to hear in more detail from the 3 excellent abstracts that follow. So I'm going to describe treatment approaches to support young people, particularly those who are struggling with adherence to antiretroviral therapy. Then we're going to look at the management of pregnancy in young women with perinatal HIV. And then finally, briefly look at some of the mental health issues faced by adolescents and young adults. I work in London, and similarly to many well-resourced settings, we actually have very few children. The majority, as you can see from the purple bar, are now young adults aged around 20, and really up to the eldest young person I look after is now 36, having been born with HIV. So really, in Europe and the US, we're very much looking after cohorts of young adults who are successfully transitioning into adult care. However, globally, those aged 15 to 19 years are the only age group where mortality continues to rise, and these are driven by the long-term survivors of the perinatal epidemic. And we see, unfortunately, that for adolescents, outcomes are poorer at all stages of the care cascade than either for younger children or for older adults. And this is something we really need to address. But actually, poor adherence and falling out of care is really a normal part of adolescence. So this is looking at sugar control in insulin-dependent diabetics. And what you can see is that from early adolescence, age 12 to 13, sugar control starts to deteriorate. But actually, when young people aged about 23, 24, you can see that things very much improve. And this is very much what we also see in those living with HIV. And actually, this is a normal part of risk-taking behavior that goes with adolescence. And we need to take risks because many of the tasks we do in adolescence are completely new to us. And we would never actually leave the comfort of our own home if we didn't take some risk. And young people living with chronic healthcare conditions actually take more risks and earlier than their peers. And this in a way makes sense to me that if you live with a condition that might be life-limiting, you may want to experience things rather faster, and your assessment of what is a risk to you personally may be different. And there's a really good reason why adolescents take risk, and that is that our brain development continues through our teens and into our mid-20s. And the thalamic drive that makes us take risk, take new experiences, develops first, and then we get the executive functioning, the frontal lobe, which is how our wishes and impulses are then more considered with our experiences. And for young people living with HIV, there are some additional tasks in adolescence, and many of them live with additional risk factors. So of the cohort I look after, half have lost one or both parents, more than half are migrants into a country. Many have experienced stigma both within healthcare, but also within families and in relationships. A third have learning difficulties, and all of those with perinatally acquired HIV have to negotiate their sexuality, their first sexual relationships with a potentially sexually transmissible disease before they have ever had sex. However, the really good news is that if we can support young people between the challenging years of around about 14 to 24, what we do see is that adherence improves along with that maturation that occurs in your mid-20s. So this is the graph of a young woman who very much struggled with her adherence throughout her childhood, but has been undetectable for the last 3 or 4 years, and her CD4 count, having been under 200 for many years, is now above 1,000. So how do we support young people to stay in services, to keep well, and to negotiate this very exciting time that is adolescence? Many, many good things happen, but there are many new experiences. And there is good evidence, and we'll discuss in the abstracts later, that adolescent-friendly services, not treating people like children, listening to their decision-making and their wishes, are extremely important in keeping young people engaged in care. In the service that I am part of, which is very much a multidisciplinary service in London, what we've found for us is that an afternoon service, that you don't need a booked appointment, that is open access, that is integrated, particularly with peer support available within the service, that you can not only get your HIV care, but also people are interested in your sexual health, your contraception, your vaccinations, your social care, your finances, if you become pregnant, your pregnancy care, testing of your partners, and a more global holistic GP care. And the segregation of services is extremely difficult. And adolescents, particularly if you don't have the money to negotiate multiple services, to change your appointments, to being able to walk in, is incredibly important. And even during the COVID pandemic, we never closed during lockdown. Now, whilst about 80% of the young people I look after have an undetectable viral load and manage their antiretroviral therapy very well, 1 in 5 at some stage in their life, and it may be when you move away out of home to college or to university, struggles with their adherence to antiretroviral therapy. And this is our schemata of how we try and support young people to prevent drug resistance, which we're going to hear about later, and to manage their health. Accepting that for some young people, there are periods in their lives where they won't be able to take antiretroviral therapy, and that care in the clinic is not just about medication. It's about engaging people in the conversation so that they manage their health. That may be their sexual and contraceptive health. It may be other important things in their lives, and looking at the structural barriers such as poverty, transport costs in attending clinic, are really important. Do you have the food, if you're on an antiretroviral regimen that's based around food such as rilpivirine, do you have access to the food to take your medication? We use an integrated model. We're very lucky, we have excellent psychologists. Occasionally we have used things like financial incentives, and more recently long-acting antiretroviral therapy, so injectables. We're really lucky now. This is, as all young people listening will recognize, this is Fortnite, the game, and this is talking about the fact that we now have regimens based around agents such as dolutegravir, such as the boosted protease inhibitors, darunavir, that have a really high genetic barrier to resistance. And this means that young people can actually have episodic adherence through those crucial years of 14 to 24 and acquire very little resistance. So you can see this is Jane. She was on a regimen based around boosted darunavir, was on and off for much of 2006 to 2012, but actually only acquired a resistance mutation against 3TC and now is fully suppressed on a small dual tablet regimen of dolutegravir with lamivudine and tenofovir alafenamide. Moving on to our second topic, this is looking at pregnancies in women with perinatally acquired HIV. I'm really thrilled that many of the young men and young women who have been living with HIV for their whole lives and in our clinic are going on to have healthy and happy families. However, when we compare those women who've been born with HIV compared to those women in the UK who've acquired HIV, usually through sexual transmission, what we see is that in those with perinatally acquired HIV, women are 3 times more likely to have a detectable viral load near delivery, And some of that is the long-term impact of having acquired resistance through the less potent antiretroviral regimens that we had in the end of the 1990s and early 2000s, and so a legacy of childhood. And some of it is the pill fatigue that goes with adolescence and into early adulthood. We've learned a few lessons along the way. This is a young woman, a 24-year-old young woman, and this is from 2018. And really in childhood, you can see her viral load, the red dots. She had struggled in adolescence with adherence, but actually when dolutegravir-based regimens and single tablet regimens became available, she'd actually suppressed from 2017 onwards, and she'd had a good improvement in her CD4 count. She was then 5 weeks pregnant, and this was just at the time that the dolutegravir alert for possible neural tube defects from the Botswana cohort came out. So we switched her to boosted atazanavir, tenofovir, and emtricitabine. Unfortunately, you can see the large red spike just under the pregnant lady. She couldn't tolerate the boosted atazanavir and had a viral rebound back to over 100,000 copies, and we therefore switched her back to Triamec, and she resuppressed and fortunately gave birth to an uninfected infant. But this was a real lesson to us about caring for young people with histories that are, show that they have struggled in the past. She had never tolerated a boosted protease inhibitor-based regimen. The risk of potential infection with viral rebound to her uninfected partner and infant, thankfully this didn't occur, but it was a potential risk. And actually, when she presented, she was already 5 weeks pregnant. And we know now that the neural tube in infancy closes by the 26th day of pregnancy. So actually beyond this time. And so moving to a second pregnant young woman, this is a young woman who had learning difficulties, had had a long-term issue with adherence to antiretroviral therapy, was severely immunosuppressed and had a very high viral load. She'd had a complex antiretroviral treatment history, but again, had only acquired very minimal resistance to the nucleoside analogues, efavirenz and nevirapine. And you can see here that for her, switching to a long-acting formulation of antiretroviral therapy that we were very kindly and able to obtain on compassionate use is the first time her virus has consistently suppressed for many years. And she then has become pregnant. She then has become pregnant and is successfully progressing through her pregnancy, her baby yet to be born, but we've continued the long-acting antiretrovirals in a recognition that she's never been able to sustain adherence on oral antiretroviral therapy. And the most important thing is to keep her virus suppressed so that she remains well in her pregnancy and that her infant remains uninfected, although there is no data as yet as to the use of long-acting antiretrovirals in pregnancy, and she's aware of this. Not to leave out the men, we know very little about the impacts of lifelong HIV infection on fertility in men, and this is some very preliminary data due to be published, which does show some concern about some features of semen analysis in men, and this certainly requires more data, although many of the young men we look after have successfully gone on to father children. And finally, just looking at mental health, the ALFI cohort was a cohort of adolescents living with HIV matched with their uninfected siblings. And what we saw is that rates of depression and anxiety were similar between those living with HIV and their HUE exposed siblings, but higher than the general population. But this in a way isn't surprising, as in the UK, risk factors for poor mental health in adolescents include Black ethnicity, a migrant population, parental unemployment, being a looked after child and living in poverty, which are features that many of the young people I work with have to have in their care. When we look at our cohort, in addition to anxiety and depression, what we have seen is an increased rate of psychotic episodes. Now, episodes of psychosis typically occur in late adolescence in the general population for the first time, but we have seen a rather higher rate, and this is certainly something to watch. Some of these episodes have been young people with drug or alcohol dependency and off antiretroviral therapy, but some have also been in young people well controlled on their antiretroviral therapy. So in summary, for young people growing up with HIV, the future is really incredibly exciting. We have agents which support young people to grow up, allow them to have an undetectable viral load, allow them to negotiate sexual relationships without the risk of onward transmission. But the path is complicated and it's quite long. And I think what I have learned from the young people that I'm lucky enough to work with is that what you need is hope, whether that be for you, hope of a cure. And this is the London patient who was the second man thought to be cured of HIV following a bone marrow transplant for an underlying malignancy. But the other aspect is that young people living with HIV want to be just like their peers. They're experiencing many of the incredibly exciting things in life, and they have many of the same issues of other young people and need the respect that all young people want in terms of achieving their care. I'd like to thank the wonderful teams that I work with, but particularly the children, adolescents, the young adults, and now the not so young adults that I have the privilege to care for. Thank you for listening, and I'm very happy to take questions now.
Thank you so much, Caroline, for that brilliant presentation. It really builds on the previous sessions that we've been having during this workshop. So that was our keynote presenter, Dr. Caroline Foster. She is a consultant in adolescent HIV infection, as well as infectious diseases. And she works at the Imperial College with the healthcare system of the NHS in the UK. Thank you so much, Caroline, for that. And I'm happy to say that my co-chair, Sadie Brown, is back online. Happy to have you back. And yeah, she had some challenges with the system when we first started, and that threw us off a little bit. But I think we're back online and everything should be good now. So over to you, you can introduce yourself as well.
Okay. Good day, everybody. My name is Sadie Brown. I am a She Decides 25 by 25 young leader. I am also a part of the youth governance group for this workshop, the HIV and Adolescence workshop. I'm also a young person living with HIV and an HIV activist. So thank you so much for bearing with me and my connectivity issues. I am here and I'm hoping that everyone is having a great time. And this is a really great session and we have worked so much to make sure that you all enjoy it. Thank you so much.
All right, Sadie, will you talk us through or walk us through the poll? Because we're supposed to have the poll session as before our keynote speaker, but because you're not online, I didn't want you to miss out all the fun. So so let's start with the poll and get going with that.
Okay, thank you so much. So everybody, so we are going to have a poll session. We have a few questions and I'm going to read them out to you and you just choose which one that applies to you the most. So the first one would be, how would you prefer to share challenges you are facing with your treatment with your health provider? A, would you like to share it in person? B, would you like to share it through SMS or WhatsApp? C, would you like to share it via phone call? So you just choose whichever one that applies to you the best, and yeah.
So you have 30 seconds to respond to that poll. And I'm really excited and looking forward to seeing what the responses would be like. Sadie, which one do you think they will vote as the most preferred way of getting in touch with their provider?
I think they will choose the SMS and WhatsApp one the most because I mean we are young people and we're always on WhatsApp anyway. So I think it would be like the most convenient one also to like be able to just have your healthcare provider on WhatsApp. So you don't necessarily need to always be at the clinic or at the healthcare facilities. Which one do you think they'd go with?
Well, I think maybe the WhatsApp as well. Definitely
Yeah.
not in. So the results are in, and Sadie, do you want to tell us what people prefer?
Yes, we just got the results, and it seems like 73% of you guys would actually prefer to do it in person. Seems like people are brave out here. So let's go on. Yeah, so let's go on to the second question. Zuzu.
Okay, you want me to read that one? Sure,
Yes.
I'll go ahead. So please, posters, get ready and let us know, what would you do if you were not happy with the service at your health facility? So would you A, go to another facility, so you'd just stop going to your original facility that you're not happy with? Or B, would you stop taking your medicines, your antiretroviral viral therapy? Or C, would you inform your health provider about the challenges you're facing? Get voting. Let us know what you think.
You have 30 seconds, guys.
Yeah. So the poll is located on the right side of your screen. Go ahead, choose what you like. And for this one, Sadie, which one do you think they'll go with?
I think they'd go with C. I think the only one that kind of makes sense would be like to actually have an honest conversation with your healthcare provider and just let them know that, yeah, I don't really like how you're treating me, so please try to work on your service. Which one do you think they'll go with?
Well, I hope, I don't know, and that's why we're having this poll. Let's see what they say.
Yeah. I'm really hoping no one goes for B, guys.
Well, the results are in. Sadie, do you want to see what the results say?
Are the results in?
Yes, they're slowly downloading.
Okay. Yay. It seems like 58% of you guys agree with me. Would just inform your healthcare provider about your challenges. So yeah, I think that's the one that really is the easiest, and it would be the most convenient for you to just have a healthy relationship with your healthcare provider. So let's move on to our third one. How would you like to be reminded of your clinic visit? A, through a phone call. B, SMS. C, WhatsApp. D, physical visit. E, no reminder at all. I am really betting on WhatsApp. What are you betting on, Susan?
I don't know. I like to have the personal interaction. So, but I'm much older, maybe a little bit not up to speed with what's current. So I do like the personal engagement, and that's why I also like the response for number 2, that individuals do feel comfortable enough to engage with their providers and talk about their challenges. And I do hope as providers, whether you're a nurse or a doctor or a pharmacist or a treatment supporter, whatever it is, that you're able to establish that rapport with your patients so that they're able to come and speak to you or somebody else when they're unhappy about the services they're receiving. Well, let's see if we have results back.
The results are in.
What do they show?
57% of you guys prefer an SMS. I think SMS is very close to WhatsApp. So yeah, you guys do it with me. Of course, of course.
I'm surprised that not so many people wanted a physical visit. I would enjoy the physical visit. I like you know, getting.
Physical visit, be reminded of a clinic visit.
Well, just talk about things, it just might not be about the clinic visit, but about my life in general. I like that personal touch. Anyway, let's go
Okay.
to question number 4. So which
Yes.
day of the week do you prefer to go to the clinic for your regular visit? So what day of the week do you think you'd prefer to go for your regular visit? Would it be on a Monday? So A is Monday, B is Tuesday, C is Wednesday, D is Thursday, E Friday, F Saturday, G Sunday. So which day works best for you to go to the clinic? Get voting. Let's see what you all think.
Well, I think Monday is like the most, it's usually like the most convenient, but also clinics tend to get very full on Mondays. So I'm not sure if I'm quite right. Which day do you think people would go with?
Well, I agree. I think Monday is a generally much busier day in any health facility. So perhaps that's what the general population would prefer. But we're talking about adolescents and young people here, so what day of the week would they prefer to go? Maybe later on in the week, or I don't think it would be week.
Probably Saturday.
Saturday. Okay.
Yeah. Let's wait for the results.
Oh, they're in now.
Yes, results are in, and it seems like 21% of you guys prefer Saturday.
Wow.
Yeah, they really.
Well, we have 34% saying Friday, so they prefer Friday, and then 21% Saturday, and then 14% prefer Monday, and 17% prefer Wednesday. So it looks like not Monday as we thought, but closer to Friday or Saturday.
Mm-hmm.
Good.
Yeah. Yeah, and moving on to, pardon?
You can go on to the next one.
Yes, moving on to the next question. How often would they like to go to a healthcare facility to see a provider for clinical services? A is once every 3 months. B is once every 6 months. C is once every 12 months. Guys, get voting. You have 30 seconds to vote.
And I think that's going to be our last question, so that we can get into the Q&A with Caroline, because we really want to get into the weeds of our presentation. And there are lots of interesting questions that are coming through. So please post your questions on the chat box. Let's start talking to Dr. Foster. Let's get some insights from her.
Oh, there's one more question.
I know there's one more, but I'm just worried that we're running out of time and we won't have enough time to chat with Caroline.
Okay.
Because I'm sure there are lots of questions coming up.
Okay.
Yeah, I know there's one more, but I want us to have enough time with Caroline and ask her questions. It was a really, really good presentation.
Okay.
All right, the answers are coming through. The results are coming back.
The results are in, and 55% of you guys would like to go to the clinics at least once every 6 months.
Okay, good. And that's about in line with where the recommendations are going there. So hopefully we'll have a lot of the programs implementing much longer intervals between visits. And so with that, Sadie, I think let's close off this poll. We won't get into the last question, but try and have a conversation with Caroline. So, yep. So Dr. Foster, are you ready to get into some questions with us?
Yeah, sure, that would be lovely. I found the poll really fascinating. We have our clinics on Wednesday afternoon because education in the UK, if you're in college or university, Wednesday afternoons tend to be free from lessons. So that's why we chose Wednesday afternoons and early evenings. But they were great poll questions. Thank you.
Yeah, really interesting responses there. So we have some questions here for you and then the chat box, and we're looking to have more questions coming through. But the first one that I can see is from Viva Torsen. I'm sorry if I'm not pronouncing that right. And I'll read it as it is. Are HIV providers actively screening for suicidal ideation then referring to appropriate services, for example? And what type of training do first-line providers get to help address this problem? Thank you.
So I think that's a really good question, and I think it's a really important question. And I think that assessment of mental health and mental health provision is the responsibility of us all, every member of the MDT, whether you're a nurse, a health advisor, a peer support worker. I think training is very variable in terms of different countries and different provisions. From my personal experience, I use 3 very quick screening tools. I ask, how are you sleeping? How are you eating? And I ask young people to rate their mood out of 10. So 10 being the happiest you can imagine, 1 being the worst. And having that scale of mood assessment means that you can compare to previous assessments of mood and see if there's a change. And that's a very quick screening tool for mental health. That means that if one of those flags up positive, that you can then spend a little bit more time delving into the situation. Because many healthcare providers just say to me, I don't have time to ask about mental health in any way. So as a tool when you're very busy in clinic, we found that to be very helpful. Depending on the responses, we would then go in more detail. We are lucky that we do have a psychologist at the moment on COVID. He's online. I really like the responses from the poll. We have, unlike many services, stayed very much face to face. I truly believe some things are really difficult for people to discuss over a Zoom call. You're never quite sure who else is in the room with a young person, who's listening in. There is how good's, like poor Sadie's had, how good's people's access to internet. Do you have phone credit? So we find that also that it's a booked appointment service, but it has open access. So that means you can come to the clinic any Wednesday afternoon and evening without an appointment, which means that people in times of crisis, particularly those who are vulnerable, can access a service without having to. They can just walk in. And we've also found for people who have been lost to follow up, although we have over 12 years, less than 5% of young people have been lost to follow up cumulatively. And that's when you ask people who haven't been for a while, they say, it's because I know that when I'm feeling brave enough or when I'm feeling sick enough, I can just walk in and nobody's going to ask me where I've been. They're going to move forward and try and help me. So I think from a mental health perspective, it's screening, listening, being supportive, referring on to appropriate service and having open access to at least your service. And quite often, referring on to peer support, I find is incredibly helpful from a mental health perspective as well. Obviously, for people who are actively suicidal, one needs to take a more proactive approach in terms of assessing their mental health risk there and then. But in general, a lot of what we see is anxiety and mild depressive symptoms. And if you can pick those up early, hopefully you avoid the progression to the point of suicidal ideation and suicidal attempt. So it's about picking those issues up early and preventing getting to that stage. And it's the responsibility of us all.
All right, so maybe very quickly asking a question on behalf of Irene, and that is, how did your project ensure increased access to SRHR services amongst the adolescents and their children and keeping their mothers alive? So there are quite a few questions for you in the chat box. So we'll try and get through as many as we can in the limited time we have.
Yeah, I mean, I think having integrated sexual health services within your HIV service. So you can tip up to the clinic, you can get your antiretrovirals, but you can also get a sexual health screen, you can get your pap smear, you can get your Depo-Provera contraception. We have free condom, and it's all about having it at one point of care. We will also do partner testing. We will also give out PrEP. for partners, for people who don't have an undetectable viral load. We encourage people to bring their partners. If you're living, say, with hepatitis B co-infection, to getting your partners vaccinated. We will provide care for the partners, and we will also follow you up in pregnancy and test your children as they're born. And it's, for me, it's often a really nice journey for young people who come with their partner who's pregnant, and then when we test the baby, we see them back in pediatric service where they were as a young man or as a young woman, and it's a completion of a life circle, really. And the fact that they are, if they're born with HIV, they feel that they are breaking the chain because they have a young child who is healthy and doesn't live with HIV. And as one of the young people said to me, you know, that's my cure, is having my child who doesn't live with HIV. I can take my tablets for that because that's my cure, which is breaking the family chain.
It's truly amazing. And Monica wants to find out whether you took a look at the effect of parental loss or having a caregiver living with HIV on mental health.
Yeah, I mean, I think that's a really important risk factor for adverse mental health. And when you look at the data, very much really whatever setting, it doesn't appear to be necessarily living with HIV that's the most important factor. It's living in a family or a setting that with HIV. So the, you know, exposed uninfected siblings have appear to have a similar prevalence of mental distress and mental health diagnoses as the young people living with HIV. And that often worries me, because young people who are living with HIV, they are in care and they are receiving care and they have access to help. Whereas I really do worry about young people who themselves don't live with HIV, but they live in a family, and how they access that care when they are suffering mental distress. And I think that's something that often as services we don't really provide for.
Okay. Sadie, there are lots of questions in the chat box. Could you look and see which ones you think you want Caroline to respond to? I'm going to ask her the next one, and then you can see which one that you think are most relevant for the adolescents and young people, and ask that one. So I think the next one, there's lots of questions from Viva, and I thank you, Viva, for being so engaged in this. I'll ask one more from you and then give other chances to ask. So she wants to know what the implications of suicidal attempts or ideations are amongst adolescents on services that are provided, or the role that the HIV program has in reducing this. And she thanks you for your presentation and responding to her questions.
Yeah, thanks you for the great question. I mean, I think it is very important that we all have a role to actively screen, and that we all have a role in ensuring young people are linked up to, a multiple different services, depending what is available in your region, and teaching young people those life skills. That we all have periods of anxiety in our lives, and that will continue for the whole of our lives. And it's about how giving young people the tools and the place of support for them to feel able to learn to manage those periods of anxiety. So yeah, I think it's a part of a holistic service, and we are all responsible for it.
I totally agree with you. Sadie, do you want to ask maybe 2 questions that you picked up from this list? Caroline, you have lots and lots of questions. I wonder whether Sadie's online, her video seems to be frozen. So I'll go and ask another question. This one from Amayan, and she says, nice presentation, but she's not very clear on the part of HIV and sperm morphology. Could you summarize what you found, and when would you know more on this from the project?
Okay, thanks. That's a very important. So there is some published data on perinatal HIV and the outcome for pregnancies and women, but there's absolutely nothing, we realised, for young men. So this was really preliminary data looking at characteristics of sperm motility, sperm counts in a very small number of young men. So, and what it did show is that not in one specific aspect of sperm function, but in multiple aspects, there were abnormalities compared to the age match norm. Now, it's a very small number. It's very preliminary data. It's published, it's in press in the journal AIDS at the moment, but it's something that definitely we need to look more at. Now, there are lots of factors that can affect sperm function, including cannabis use, including alcohol. So none of those were adjusted for, but we really just had we talked to the young men in our clinic and said, we're very mindful that actually we do a lot for young women and their fertility, but less for young men. And that paper also has some data on fertility aspects for young women as well. So I think we don't know, but I think it's an unexplored area, and that the young men in our clinic deserve the same access to proactive screening and to research that the young women do. So we're just very mindful that sometimes the young men get left out.
I agree with you. Sadie, are you back on now? Is there a question?
Yes. Hi, Doctor. There's Chisoni Banda from Zambia, and she'd like to know, with the impact of the COVID-19, it has been noted that the access to SRH services have been drastically affected. So how do you think the access to SRH services can be enhanced, more especially that it seems like COVID-19 has come to stay?
And I think that's a fantastic question, and it's something that we have all struggled with in every setting. We were very lucky. They tried to close us down, the service, and make it all go online with COVID. But we pointed out to them that we're not just a booked appointment service, but that we have walk-ins, and therefore people without phones or who are homeless will continue to walk into our service, and therefore we can't shut. So that allowed us to continue the service and to continue our sexual reproductive health service, which was incredibly important. I think, more widely, COVID is here to stay. We have to learn to live with it. Young people are very unlikely to get sick with COVID-19. So we have to think that young people friendly services must stay open and serve young people. And I think we all have to advocate extremely strongly that this is not acceptable, that it's not acceptable for your long-acting contraceptive or your PrEP supply to stop because of COVID-19 when you are in your 20s and coming to hospital. Even if you come across COVID, you aren't going to get sick with it. So I think it's about us advocating that, we've all advocated for young people's services so hard, we have to continue and double our efforts in the COVID era, because there is no medical reason for young people's services to close because of COVID.
Yeah. Thank you so much. And the next question is from Jeremiah from Zambia as well. And they are saying, what would be your advice to healthcare providers who judge when adolescents visit the facility to seek HIV treatment support and care?
Yeah, I think that's a really good point. I think young people are stigmatized, not just within healthcare, but in society. Recently there's been a lot in the UK press about young people catching COVID and spreading it. But, as everybody said, okay, you tell young people to go back to school and university, of course there's going to be spread of COVID. But demonizing a section in society does not make people want to go and access care. So when a young person presents pregnant late in the 3rd trimester because they're scared they're going to get shouted at, all that happens is they do get shouted at. And that just reinforces the fact that, I'm not going to access care because it's going to be a really negative experience. And everybody was a teenager once, and most of us weren't perfect when we were teenagers. So it's about having a little bit of empathy and communication and pointing out that shouting at anybody never changed behavior for a teenager. It always does the opposite.
Sadie, can I ask 2 quick questions and maybe get 2 quick responses from Caroline? One is from Dr. Linda Gale Baker, and she wants to know about safer conception for young people in your clinic who may have partners who have a disorder status. And then another interesting one that I saw was around drug holidays from Emily, like in the period of adolescence, where some adolescents struggle with adherence. What do you say about drug holidays? Wait it out, continue, what happens with resistance? So maybe some quick responses to those.
Okay, yeah, no, to Linda's question, which is always, so the majority of our couples in our clinic are discordant. More than 95% of those who are planning pregnancy within a stable relationship have an undetectable viral load. We will offer partner prep in the very rare cases. We all know that the risk-taking behaviours go together, so most of the unplanned pregnancies are in those with detectable viral loads, and they're already pregnant by the time you find out, so it's not possible for preconception counselling. But we do encourage those, planning pregnancy to come and see us, to start their high-dose folic acid, for both partners to get a sexual health screen and discuss the need for PrEP. But in our experience, the majority who are well engaged and planning pregnancy are already undetectable. And the second question about drug holidays, that's a really, really good one. I think we're moving into an era where we are incredibly lucky that the experience with the second generation integrase inhibitors, so dolutegravir and in our setting also bictegravir, is that you can go on and off your antiretrovirals without acquiring resistance. Now, I am not a big fan of drug holidays. I am, with the newer antiretrovirals and the boosted protease inhibitor, darunavir particularly, I am much keener to say, let's look at how we can help you improve your adherence rather than giving you a time off. Lots of young people will take their own drug holidays anyway. And if you stop and start those medications, so the dolutegravir base that we're all globally moving to, it's obviously very different with efavirenz based regimens in that poor adherence or drug holidays, because the efavirenz tail is so long, is likely to be associated with resistance. But I think it is the beauty of moving to the higher the higher barrier to resistance drugs such as dolutegravir, in that it really allows, as we saw from those graphs in the talk, that people for 10 years in a setting where I have ready access to viral load testing, but actually I don't need it because I know with those regimens with a high genetic barrier that the risk of requiring resistance is extremely low. Some people are not lucky, okay, but the overall risk is very, very low. And whilst I wouldn't sanction a drug holiday as a good idea, because you will get CD4 count drop, if somebody is on a drug holiday, I will roll with that and look at, okay, what do we need to change in you, when do you see in your life that you think you're going to restart medicines? And I would never, be punitive about a drug holiday. I'd say, okay, because everybody knows that you should be on your meds. So there's no point being in any way judgmental or punitive. It's about exploring, why did you have to stop? Can I make things easier? Were you getting side effects? Is there less pills? Do you not have, enough to eat when you're taking your meds because of the taste is horrible? Is it because your brothers and sisters or your cousins who you live with don't know about your HIV and you're hiding meds and you can't get to access them? So it's exploring those barriers. Or is it just that you are fed up and you don't want to talk about meds for a bit? And let's talk about something else, because there is more to life than meds.
There sure is. So Sadie, one last burning question from you that Caroline can respond to.
So there was another question from Jeremiah from Zambia, and they were asking, how would integrated care for adolescents be navigated where parental involvement may be important?
I think that's a fabulous question and incredibly tricky and incredibly family specific, because you are trying to allow a young person their own voice and to listen to what they really, really want. Yet we all need help from other people to negotiate life. It's not an age thing, and it may move from your parents or carers to your friends, to your partner, but we can't do it on our own. So it's about spending some time. So once an adolescent is 12 or 13, I start spending, or one of the nurses, a few minutes with the young person on their own, and then some with the carer. And then we increase that so that by the time you're 16, you may well be coming to your appointment on your own. But you can always, even when you're 25, you can always bring your parent or carer or partner or friend, but it is your choice. In the UK law, from 14, actually, young people have a right to medical confidentiality. So it is different. And from 16, they can consent to pretty much everything on their own. Obviously, that is different for young people with learning difficulties. So it's a real balance between, and the lovely thing for me is I've known a lot of these young people and their families for 25 years. I've been in the same setting. So it's a huge privilege to know somebody from birth to 25 and to see them having their own children. And there are bumps. I often, don't feel that you get the balance right between the adolescent and parent. I tend to veer towards the adolescent and try and keep the parent involved and not feeling isolated. But my confidentiality and my role going forward as they go through their teenage years and into a young adulthood is to that young person. So it's about putting the young person at the middle and trying to explain to parents and carers just why you're doing that and trying to have a very open conversation. But yeah, it's really tricky and you don't always get it right, but you give it a good go.
Thank you so much for your contributions, Dr.
Yeah, thank you so much. That was a fantastic opening to our session, Alive and Thriving, and you've convinced us beyond a reasonable doubt, if we had any doubts, that we can be alive and thrive despite our HIV infections. And thank you all for the engagement, for the numerous questions. I apologize we didn't get around to all of them, but they're in the chat, and hopefully Caroline might have some way maybe to respond to some of them. So with that, unfortunately, we'll go to a quick break, grab your coffee, bathroom change, grab a quick snack, and we'll see you back in 5 minutes. Thank you.
Sebele sebele bula segele enar on Maradona dlala rock enar on Vigro dlala rock I sit trap take it أنا قستابت كل شلل بيجنا الكلل جابو سبل ولا سجل أنا قستابت كل شلل بيجنا الكلل جابو سبل.
Welcome back, everybody. I hope you had a good break. I know it was short. And I see that Caroline has been responding to some of the questions in the chat box, and we'll continue to do that through the rest of the session. So I'm really happy now to present to your abstract presenters. Our first speaker is going to be Debeme Jume from the International Reference Center for Research on Prevention and Management of HIV, and she is based in Cameroon. She'll be presenting her abstract on virological failure that is acquired with HIV drug resistance among vertically infected adolescents. This is evidence from the EDCTP funded study that was conducted in Cameroon. Debbie May, over to you. I'm really happy to have you.
Hello everyone, my name is Anne Selberg and I work for AfricaAid, and today I'm very happy and honored to have the opportunity to share about our viral load quality improvement project for children, adolescents and young people living with HIV, and sharing our experiences from Zimbabwe, January to March 2020. So through the session, I'll go through the background, an overview of the Shandiri program, how we selected our sites, viral load deep dive, viral load quality improvement and way forward. So the AfricaAid Shandiri model is built on CATS, Community Adolescent Treatment Supporter, who are HIV positive, 18 to 24-year-olds, young people living with HIV, who serve as a linkage between the community and the health facility for children, adolescents, and young people living with HIV. So last year we analyzed our Q3 performance, and we could see that the adolescents and young people were lagging behind in terms of viral load suppression and viral load coverage. So we decided to select 1 highly performing sites and 7 low performing sites and implement a viral load quality improvement project. So we extracted the programmatic data, and we found the best performing site was Cholocha District Hospital, who had 91% viral load coverage and 94% suppression rate. And then we selected 7 sites from Shimba and Goromonsi that had 18 to 26% viral load coverage and 53 to 68% suppression rates. Our methods that we developed was to have on-site discussions, interviews and observations, meeting with Ministry of Health at district level and site level, in-depth interviews with key staff members, observations of CATS home visits, focus group discussions with children, adolescents and young people living with HIV. So the best practices that were highlighted by the staff at Cholocha District Hospital were teamwork, that they divided the responsibility for the different registers and they collaborated to ensure that several staff could participate on the adolescent days. Also provision of adolescent friendly services, use of adolescent friendly language, patient kind and caring attitudes, and provision of combined art refill, viral load beading and support group module during a Saturday. And then actively using data for program development and improvement, and developing a viral load QA plan, an active follow-up and revision of that plan if need be. So this is what we saw when we came into the OI department. As you can see, they've done a fishbone analysis, problem analysis, they developed specific activities, and they even had a run chart where they had monthly targets and they were reviewing their outcomes for this target. So this is what we found when we went for home visits with the CATS. The client said, when I have a problem, I talk to my friend, and they indicated the CATS. They also said, it was nice to go to a support group because you feel like you're a part of a family. I just felt so happy and free. It's even better than being at home. Have a lot of friends there now, have gotten used to them. The topics are quite interesting, the way we are discussing it. It is easy to understand. I've been 3 years at the clinic. They are fast and they don't harass anyone. They do their things on time. And this is an example of what the CATS was saying to the caregiver of a client to encourage him to support the client to take his ARVs. If you take your pills well, no one can see that you have HIV. If you don't take them well, everyone can see. And the cats indicated herself as an example of that. We also interviewed the OI nurse at Charlotte District Hospital. She said, we talked to the adolescents and young people and they wanted to be seen during the weekend. A lot will be going on during the week. If the parents see them, then there will be a lot of talks. Us as OI department, we have monthly discussions regarding the viral loads and new registrations. For example, if we have an increase in the number of high viral loads, then we try to find out why. We try to find the cause. There was a month when we noted that we had lots of children with high viral loads, so we invited the caregivers to come for a discussion. This other boy, 7 years, his grandmother goes to South Africa and leaves the boy behind. Another had stopped taking medications because of exams. And finally, they are taking our service as well. We know because they will come for appointments even if it's not their review date. Then we also did focus group discussions with adolescents living with HIV. They said we work well with the cats. They talk like friends and we discuss issues and we share. The cats can spend the whole day at my place if she's not coming to work. We are just talking about life. And then about the healthcare workers. They are just like your friends. We discuss issues freely. And she asked me how I take the medicines, if we have any side effects, and they explain clearly why we shouldn't stop taking the medications. Sometimes they even put the adolescents in front of the adults and serve them first. So after this, we went on with the viral load quality improvement process, and we developed a rigorous system of evaluating viral load monitoring at health facility level, including review of tracking registers to see if those in need of adherence counseling and viral load were tracked, review of viral load registers to see if they were bleeding enough to reach their annual targets, review of patient files to see if they had a valid viral load result and if they were booked for adolescent days, and review of high viral load registers to evaluate for any delays and quality of services delivered. What we could see was that the majority of them didn't know how many adolescents they had at their sites. They also had the review of the green files. We could see that many of them were not booked for adolescent days. And from the high viral load register, we could see that some sites had very good quality of care while others were lacking and there were some considerable delays. So this is how we develop our viral load QI plans, including aims, objectives, and specific activities. And we wanted to line list the clients who are due for viral load bleeding, mobilizing them for viral load bleeding, weekly follow-up with lab, engaging district medical officer regarding delays, case conferences for adolescents with high viral load. And we also wanted all relevant cadres to participate in the adolescent. And this was the outcome after 6 weeks. As you can see, we moved from being in red to being in green and yellow. So out of the 596 adolescents that participated in the viral load QI exercise, 224 were bled for viral load. So we went from 38% coverage to 80% coverage. When it comes to valid viral load, we went from 38% to 69%. And number with suppressed viral load, we went from 45% to 79%. So as a way forward, we recommend documentation of best practices and sharing with relevant stakeholders, training of all staff in quality improvement process, cascading the viral load quality improvement process to all other AFRICAID supported districts, and engaging key stakeholders for joint ownership of the quality improvement targets and goals. Our experience was that this was very successful for improving viral load monitoring of adolescents. Thank you very much.
Hello everyone, I'm presenting virological failure is consistent with acquired HIV drug resistance amongst vertically infected adolescents. I'm Dibmen Jume, presenting on behalf of the ETC-PCR ICV team. We're going to follow this plan. To begin with, there's been a relative decrease in HIV-associated mortality globally, but adolescents living with perinatal HIV infection continue to experience 50% rise in mortality. This prompted us to carry out a study with aim to assess response to antiretroviral therapy, HIV-1 genetic diversity, and patterns of acquired HIV drug resistance. Our specific objectives were to determine the rate of immunovirological response, acquired HIV drug resistance mutations rates, and HIV-1 subtype distribution potentially active antiretrovirals, and early warning indicators of HIV drug resistance. We carried out a cross-sectional analytical multi-site study over a span of 5 months. Following consecutive sampling, informed consent was obtained from parents and guardians and assent from adolescents. Participants were enrolled from 2 pediatric urban centers, from where self-reported adherence, WHO clinical staging, and early warning indicators were assessed. All samples collected were transferred to the Chantal Biya International Reference Center for Research on Prevention and Management of HIV, where CD4 count, viral load, and genotypic resistance testing were. In total, we enrolled 196 participants, amongst whom majority were female in late adolescence on first-line antiretroviral therapy, that is, on 2 nucleoside reverse transcriptase inhibitors and 1 non-nucleoside reverse transcriptase inhibitor, and over 30% were observed to be poorly adherent to therapy. Majority of the adolescents were asymptomatic with a clinical failure rate of 9.2%. Determination of immunological failure defined by CD4 count below 250 cells was seen to be 15.8% in our study population. Predictors of immunological failure were advanced age, female gender, and poor adherence to therapy. We observed that the virological failure rate was as high as 34.2%. This could be explained by the fact that these adolescents have been on long-term exposure to low genetic barrier antiretrovirals. 65.8% were seen to be virologically suppressed, that is below 1,000 RNA copies per mil, and only 66.6% amongst these had unstable viremia, implying that there's still a lot to be done for the 90-90 target to be met. Predictors of virological failure were first-line antiretroviral therapy and poor adherence to therapy. HIV drug-resistant mutations rates were as high as 92.2%, associated with being exposed to non-nucleoside reverse transcriptase regimens. Dual-class resistance rate were as high as 76.6%, as seen on the bar chart. After observing genetic variability in a study population, it was seen that the predominant subtype was circulating recombinant from 0 to AG. There was discovery of 2 new potential strains, unclassified recombinant from A1G and GA1. Could this have any impact on treatment response and disease progression? Well, antiretrovirals which were most potent in our study were tenofovir for nucleoside reverse transcriptase inhibitors, doravirine for non-nucleosides, and darunavir for protease inhibitors. Driving factors of HIV drug resistance were delayed drug pickup, recurrent drug stockouts, which is still a major problem in resource-limited settings like ours, and poor viral load suppression rates. In conclusion, predictors of immunological failure in our study were older age, female gender, and poor adherence. Virological failure rate is high due to a high HIV drug resistant mutation rate and due to poor adherence. There's also a high multi-drug resistance rate due to the use of low genetic barrier drugs, which requires third-line ARV use. Active drugs for these participants would notably be tenofovir plus amivudine backbone, plus all protein inhibitors and integrase strand inhibitors. Factors favoring HIV drug resistance were recurrent drug stockouts, delayed drug pickup, and poor viral suppression rates. Hence, in order for us to effectively transition from adolescent care to adult care, there is need for improvement of drug supply, enhancement of adherence, particularly in female and late-age adults. This is a brief summary of the findings we got, and we observed that for all patients with these risk factors, advanced adolescents, female gender, poor adherence, there's high suspicion of immunological failure, which should require biannual CD4 count monitoring and reinforced adherence. For those on first-line antiretroviral therapy and those who are poorly adherent to therapy, there should be suspicion of virological failure, which would require reinforcement of adherence still and closer viral load monitoring until the attainment of viral suppression. Potent drugs for treatment failure would be the tenofovir plus amivudine backbone, plus all protease inhibitors or integrase strand inhibitors. We would like to acknowledge the HIV and Adolescence Workshop team for granting us this platform to present our findings and to share, Virology Education and Partners, European and Developing Countries Clinical Trial Partnership, ICB, for the funding, the collaborating clinical sites, and to the adolescents who participated. Thanks for your attention.
Next up, the last video we have Claire Hefmeyer, and she is presenting on reducing mother-to-child transmission amongst adolescent girls and young women in low-income and middle-income countries. Welcome, Claire, and thank you so much for your presentation.
Hello, my name is Claire Hofmeyer and I'm a research associate with Mothers to Mothers, an African-based health NGO that recruits, employs, and trains women living with HIV as mentor mothers. My presentation is a multi-country review on reducing mother-to-child transmission among adolescent girls and young women in low and middle-income countries. This study has been co-authored with my colleagues, Agnes Ronan, Marjorie Mbule, Jude Eggenbaugh, and Catherine Schmitz. Despite high ART coverage in most countries in sub-Saharan Africa, adolescent girls and young women have lower uptake of treatment and experience inferior outcomes at many points along the prevention of mother-to-child transmission, or PMTCT cascade. For example, they are less likely to know their status before their first ANC visit, they have a poorer understanding of how to prevent mother-to-child transmission, and they tend to experience greater delays between diagnosis and treatment initiation. Given this, it is unsurprising that multiple studies have found that the odds of MTCT were 2 to 3 times higher among mothers aged 10 to 19 than among those aged 20 and older. Early and sustained utilization of PMTCT interventions is essential for success in bringing down the MTCT rate. This study contributes to the pool of research on the positive impact that peer support has in the fight to eliminate mother-to-child transmission of HIV among adolescent girls and young women across 6 sub-Saharan African countries. Working across 10 countries in sub-Saharan Africa, Mothers to Mothers employs, trains, and empowers HIV-positive women as lay healthcare workers. Our mentor mothers work in local communities and at understaffed health facilities to ensure that women and their families get the health advice and medication they need and to stay in care. As frontline health workers, they provide various services to bring pregnant women and new mothers into care and to keep them in care during the PMTCT period. These include household mapping for early identification, referral and linkage to services, active client follow-up for missed priority appointments, support in accessing infant prophylaxis and testing, and guidance in safer feeding methods. In our study, we conducted a retrospective analysis of a 36-month cohort of adolescent girls and young women supported by the M2M program. We used a cluster random sampling design to select 69 sites across Eswatini, Kenya, Lesotho, Malawi, South Africa, and Uganda. All pregnant women and new mothers who enrolled into the M2M program at these sites between the 1st of January and the 30th of June 2016 were included in our study. Data were collected for all interactions with a mentor mother from the time the client enrolled until the end of 2018. In total, the sample includes 2,462 women aged 10 to 24 years old at the time of enrollment with M2M. Our sample of pregnant women and new mothers had the following characteristics. 80% of the sample were young women aged 20 to 24 years old at the time of enrollment with M2M. The remaining 20% were 10 to 19 years old. Just over half of the sample enrolled during the antenatal phase, or in other words, while pregnant. Only a third of those who were pregnant at enrollment with M2M attended their first focused ANC visit at the clinic in their first trimester. Just over half attended in their second trimester, and 13% attended in their third trimester. 97% of the women in our sample were initiated onto lifelong ART, and among those, 90% were initiated during or before pregnancy. We find the following outcomes for infants along the PMTCT cascade. The vast majority of infants, 90%, received their first PCR test between the ages of 0 to 8 weeks old. Uptake of the final test at 18 to 24 months old was lower at 72%. Among all women delivering, we find a transmission rate of just 2%. If we restrict the sample to those infants where we know their status at 18 to 24 months, the transmission rate was 2.9%. The 95% confidence interval around both of these statistics falls below 5%, indicating that virtual elimination was achieved. Among infants who seroconverted, uptake of ART was high at 83%. Our findings show continued late entry to PMTCT services among adolescent girls and young women. This may suggest that this group does not engage with sexual and reproductive health services sufficiently or at all before pregnancy. However, once identified and linked to care, testing uptake, mother-to-child transmission, and uptake of ART among HIV-positive infants compare favorably with outcomes in Eastern and Southern Africa as a whole. For example, the UNAIDS Data 2019 report found that over all women aged 15 to 49, 68% of infants received the first test as compared to 90% in our sample, and the MTCT rate was 9% as compared to 3% in our sample. This may suggest the positive impact of the M2M peer-based model on MTCT outcomes in this group. To maximize PMTCT outcomes for adolescent girls and young women, there is an urgent need for innovative interventions that target this population group early to provide a supportive sexual and reproductive health environment for those who fall pregnant. M2M is currently piloting such a program in South Africa called HISP, High Intensity Interval Service Provision. In this program, youth facilitators and young mentor mothers deliver modular group education sessions to empower pregnant and breastfeeding adolescent girls and young women with information to enable them to make informed choices about their sexual and reproductive health, pregnancy care, and parenthood. Thank you very much.
So much for your presentation, Claire. Now we are going to go on to the panel discussion and a Q&A. So we do have a few questions from various people, and I am just going to start with the few that I can see so far. And I have this question from, wait.
So while
So
Cindy questions, okay, go ahead, you're back on, go ahead.
I'm so sorry. I have a question from Amian Wole, and they are saying, great work. Are you also looking into sustained viral suppression rather than one-off suppression? And the next question that I see here, it's from Irene Ogeta, and she is saying, how is your project also aiming at preventing unintended pregnancies among the adolescent girls and young women? A really good question to which we are all trying to get better at. And COVID definitely hasn't made it easy. For young women living with HIV, we really try to get them onto a long-acting contraceptive. So the Depo-IUS implant and getting young women onto DTG-based regimen means that all contraceptive options are available to them. Thank you.
Thank you very much. I think to the first question, is it okay if I go ahead, by the way?
Sure, go ahead, Anne.
Yeah, so to the first question, we're actively tracing those who are going from our standard care, which means that they're virally suppressed among others, and towards enhanced care. So we're not just tracing a one-stop, we continue to trace it over time, and we also provide a standard package to those who are TND, so that we ensure that we don't just get them from a high viral load to low viral load, but keep them having a suppressed viral load. So that's part of our Africa Chandira program and ongoing support. For the other question, how we prevent unintended pregnancies, especially during COVID, we were linking them to other organizations that were providing community contraceptives. But through our CATS program, we also make sure that those that are sexually active are linked to the health facility for contraceptives. And we also do that during support groups. We give SRH information and linkage to services during adolescent days. But it's an ongoing challenge, especially with healthcare workers' resistance towards providing contraceptives, and also myths and misconceptions around contraceptives, where the young people think that you become infertile if you have if you take contraceptives, and they're afraid of stigma.
All right, good responses. And there was another question I think that was intended for you. And this is, what is or was done to anticipate and avoid the scenario where a caregiver travels, leaving the child behind and no one there to ensure adherence?
So I think there we really need caregiver support. So we provide that both through caregivers meetings, where we're involving the caregivers actively so they understand the importance of supporting their adolescents. And also when the cats go and support their adolescents, they also actively support the caregivers. But even though we're doing this, we see, especially in that region, up in Chilocho and Lupane, which is a border region, that there are quite a lot of our adolescents who are failing, who are receiving insufficient support. So what we try to do when we come into those situations is that we have multidisciplinary case management meetings, where we discuss how we can link them to other support figures close to them, how we can link them to, if we can't find someone close to support them, a village health worker or someone else to provide support, and also through the health facilities. We try to engage different stakeholders and cadres to make sure that they get the support, but it's an ongoing challenge.
Okay. Thank you for those responses, Anne. There are quite a few questions for you, but what I'll do is break it off and ask Claire to have a go at her question while you look at some of the questions that have been put forward for you, Anne. So for Claire is, how do you find the linkage and communication between HIV clinics and the antenatal clinic? Are there lessons on this to help improve issues, including late entry? And this is from Amian.
Thanks for the question. Can you hear me all right? I'm just not sure if my headphones are working. Great. Okay, so in cases where the HIV clinic and the ANC section are in the same building or in buildings that are close to each other, a mentor mother would be responsible for guiding the client between the two sections where necessary. In cases where they're not in the same location, how we work is that we'll be quite concentrated within a region of a country. So, for example, there are a number of facilities within a relatively close area in the Western Cape in South Africa in which we work. And the mentor mothers across these facilities communicate and will be able to tell a client in one place, if you go to this other facility, you can see another one of our mentor mothers there and she can help you there. So there's quite good communication between facilities that we work in. And then in terms of late entry, the other thing that many of our facilities running our program do, but not all, is we have what we call an integrated service platform, or where basically we have mentor mothers working in the facility. So they sit and are based in the facility and see patients as they come in, but we also have mentor mothers working in the community. And they work hand in hand generally with the facility mentor mothers, either going to visit clients at households who have already enrolled at the facility, and this is now following them up in the home if they've missed an appointment or if they're high risk and need some more support. And in some cases, they're actually enrolling clients in the community. So their first visit would be to a household in a community, enroll them in the program and refer them to care at the facility. So it's really at that point, when we're enrolling clients in the community, seeing them first there, that we might pick up adolescents and encourage them to go to a facility because they're kind of entering it late. If it's in the facility, we're seeing them when they arrive at the facility, but then we're making sure that we follow them up for them to come back to the facility often, as well as to visit them in their homes if that seems like it's necessary.
Thank you for that, Claire. Sadie, did you want to ask Debbie May her question?
Yes, thank you so much. At Debbie May, is subtyping feasible to be done outside of a study setting? And could you expand more on the implications? Really interesting analysis. This is from Monica Kamkuma. Thank you.
Thank you for the. Is everything all right? Can everyone hear me?
Yes, we can, Debbie May. Go ahead.
Okay. Thanks for the question. Well, it's feasible to do subtyping even outside of a study setting. Basically, it's not routinely done in our setting due to unavailability of resources. But I believe in the Western world, it's something that's done systematically for every patient. For the implications, it's important to know the subtype because it could give us an idea of disease progression For example, we know subtype A, or sorry, circulating recombinant from 0 to AG, which is very predominant in our setting, does not have a lot of impact on fast disease progression. So having an idea of the subtype gives us an idea of the disease progression, to know how aggressive the virus or how virulent the virus is, the strain of the virus is. Thank you.
Thank you so much.
There's another question for Debbie May. Maybe Sadie can ask her that too, and then we can switch over to questions for Anne.
Yes, Debbie May, there's another question. Marianne Bija would like to ask, she's saying, thanks for your presentation. Can you also discuss why you didn't include VL test results alongside CD4 for your study cohort? Viral load testing is available for free. Thank you.
Okay, thank you for your question. Well, at the time the study was done, the viral load was paid for every participant. Reasons why we didn't put the CD4 count and viral load alongside were because we had to take these values, how do I put it? We had to take these values from the time the adolescents were followed up, that's from birth, through to the study time. And to actually get a mean viral load wouldn't have been representative of the clinical picture at the time. CD4 count, well, from the recommendations by WHO at the time, it was stated that immunological failure, was defined by a CD4 count of less than 250 cells. So to be conclusive, at the time when the study was done, viral load testing wasn't yet free in our setting. It was paid for. It's only as from the beginning of January 2020 that it was made free to all participants. Thank you.
And there are a few questions for you here. I'm sure you've been keeping track of the chat box. Do you want to try and take a stab at as many as you can for like a couple minutes, and then we can switch over to Claire?
Great, thanks. So I think the first one is from one of our cats who asks about what causes drug resistance if the person's adhering well. And there can be several things causing that. One is, of course, drug-to-drug interaction, especially with TB drugs. That's what we've seen. And other is that actually with time, it can happen also for those, especially on Tenolom-E or on those first-line drugs. But most of all, there's a history before of poor adherence that then later on in later years also leads up to drug resistance. Then there was a question, thanks for an excellent presentation. Can you share more about the context national support for QI methods in Zimbabwe? Is this part of HIV policy? So it's actually a QI focal person at national office with Ministry of Health is doing an excellent job with QI. So it's not just us doing QI, it's something that's happened in many places in the country. We engaged Ministry of Health at district level when we did this QI process, so they were also part of it, but it was only later that we started getting integrated into the national team's QI process. Then there was also, with regards to the CATS intervention, to what extent were adolescents and young people engaged in the quality improvement process, and what would be the impact on the process? So the young people were part of line, or the Shandiriment were part of line listing clients, and then the young people were the ones who mobilized clients to be bled for viral load. And they were also part of e-support group sessions where they were explaining about what is the importance of viral load and what, so it's demand creation and mobilizing for the health facility to come and be tested. But this was mainly in the first part of the quality improvement. We're now moving on to really looking at viral load suppression, and then of course they have an even more relevant role to play when it comes to finding out the issues, the adherence issues, and also motivating clients to take their pills. Then let's see. And did you look at side effects and resistance? Yes? I'll stop there.
Yeah, side effects and resistance. Go ahead.
Well, I'm not sure if that was for me, but we looked mainly at increasing viral load coverage and viral load suppression rates. So that was not really looking at the side effects and resistance. We didn't go to that level. It was more looking at adherence support and how to provide adolescent-friendly services. we didn't have any lab resources for this quality improvement. Then let's see. I think those were all for me. Now here's one more. Can you please share your experience when you were conducting the study, whether the healthcare providers accepted your ideas or any other challenges? Can you share your study for learning? So it was different, like when we did it in Shimba, and some sites with extreme good support from healthcare workers and from other community cadres. So they were collaborating as a team together to do the quality improvement plans. While in one of the health facilities where we didn't do so well, we didn't have good collaboration from healthcare workers. So what we found is that it's really key to have that collaborative teamwork process for the quality improvement to be successful. And part of that is, of course, that you set the targets together and everybody are owning those targets, that we don't impose the quality improvement process on the team.
Thank you so much, Anne, for that detailed explanation to all the questions posted for you. Claire, can we switch over to you now? I see a couple questions for you there. So
I'm
with
not
the first,
sure if I'm seeing them. Which ones, because I don't see my name. Which ones are directed at me?
I'm assuming that it's coming to you. There's one that's talking about, it would seem that younger adolescents become pregnant and not taking any action about it for many months. Is there any programming around this? This is a question from Mark Thorpe.
So sorry, I didn't see my name. So
It doesn't have your name. I just thought it was more in line with what you were doing. So the question, it says, it seems that when younger adolescents become pregnant, they're not taking any action about it for many months. Is there any programming around awareness raising specifically in what a girl should do on learning that she is pregnant? Is some of the problem a preference to be in denial about being pregnant or not being able to tell others, or lack of discreet access to prenatal services?
I'm not sure how much I can speak directly to this one. The program that I mentioned at the end of my presentation, HISP, High Intensity Interval Service Provision, that's about bringing together girls, women, young women, aged 10 to 24, who have come to the clinic. And they may have come to the clinic for something else, but they've realized that they're pregnant and they're HIV positive, and they may know the one and not the other, or they may find out both at the same time. But they have come to a clinic. And so they are already in some phase of not being in denial about their situation. So part of the programming is certainly about trying to prevent subsequent unintended pregnancies, but that program is dealing with adolescents who are already pregnant and aware of it and accepting it to some degree. And I was going to say, it's not really answering your question, but just to say that that program we're trying to improve access to it by offering it virtually as well as in person. And certainly the virtual side has been prompted by COVID, and it'll continue to be provided virtually and in person.
Okay. And then there's another one I thought that maybe you could speak to from your experience. And this one is coming from Yawira Gitahi Kamau. And it's how do you provide psychosocial care seeing the intersection between adolescence, pregnancy, and in brackets unwanted, HIV diagnosis, and transition that is unintentional into adulthood, because they often can't fit into their adolescent groups or days anymore. Is this something that you can?
So I guess partly this is where the fact that these modular group sessions can be virtual, that'll assist, not being able to come to a clinic on a certain day. If we're offering two types of services, either you can join a group, which is beneficial, for reasons many people know, you're making friends, it's a nice structured setting. But equally, clients can come at any time of day that they want when the clinic is open. And there are now increasing virtual services where you can talk to a mentor mother over WhatsApp or over SMS. So we're trying to target it, kind of give clients access in as many ways as possible. So if there's a specific group day or time they can't come to that, they can come on their own and receive one-on-one services, which some people prefer because then it's private.
Mm-hmm. Yeah, and just on that, Claire, what platform do you see most adolescents or young women using to get in touch or to communicate with the mothers to mothers, and maybe reflecting on what we saw from the poor results about the preferred way of communicating with providers?
I think we're doing pretty well with WhatsApp, but it's something we're working on and expanding. A lot of work is going into providing the support in as many languages as possible, which, given that we work in, I don't know, at least 10 countries at the moment, it's a large number of languages. So we're really trying to make it as easy to access as possible. And some of that follow-up or that assistance that we provide is us phoning them if they've missed appointments. So then they wouldn't be incurring any cost, but they'd be on the phone with us or receiving SMSs. And then where we run that community program, we're visiting households where that's, they're happy for us to do that, because obviously that can cause issues around disclosure. If the client that we're seeing hasn't disclosed, they might wonder why Mentor Mother is visiting them, but where that's permitted, we do that as well.
Okay. Sadie, some thoughts or reflections on the 3 fantastic abstract presentations we've just had?
I'm really satisfied with everyone's presentation. I think they were quite informative. And as a young person living with HIV myself, I am quite glad I really feel represented in the presentations. And I'm hoping that everyone else who's watching here does kind of feel the empathy and a little form of representation from our speakers. Thank you so much to everyone.
Yeah, this has really been fantastic. And I must say that we received fantastic submissions for this session in terms of the abstract. And it was really, really hard to pick these top 3 because really they're fantastic, well done abstracts. And we struggled to pick the top 3 for oral presentation. I do hope that everybody will stay on and see some of the abstracts that will come through the poster session. So right now we're running out of time. It's amazing how quickly these sessions go, but we're getting ready to transition to the video. And I'm going to introduce my co-host Sadie, who's part of our video for today. She has an interesting story to tell, and I didn't think that would do justice to it just with this short interaction that we've had with her. And then the second video that you see is from some of the work that's been done here in Zambia, in the western part of the country, in a really hard to reach population. So thank you to our oral presenters, fantastic oral presentations, fantastic responses to the numerous questions that we received. And a big round of applause to you and to Caroline as well, our keynote speaker. So let's transition to the video.
Hello, my name is Sadie Brown and I am 25 years old. I am based in South Africa and I am a young person living with HIV. I was born with the virus and I have been on treatment since I was 18 years old. So I've been on treatment for about 7 years now. Being on treatment for me really has been a long journey that has been filled with ups and downs, because when I started I was quite scared of being on treatment. I was so scared of the side effects. I remember the first time I was told that I needed to get on treatment, the first thing I did was go on Google and I searched for the side effects of ARVs, because from school that was literally the only narrative that was always being passed on about ARVs. We were literally being told that being on treatment, being on HIV treatment means that you get diagnosed with HIV, you spend the rest of your life being on these pills that are meant to make you feel better, but they will also make you sick because of the side effects, and eventually you will die. So as a teenager, I was quite scared of the side effects. The first thing that came to my mind when I was told that I had to be on treatment was the side effects. And of course, Google told me things like my hair was going to fall off and my teeth were going to fall off and I was going to lose my mind. And as an 18-year-old, I was so scared. I remember just crying and feeling like, I am just 18. I don't think I'm ready for all those things. And in my mind, I looked at ARVs and I just felt like they were meant to just make me feel shameful for living with HIV. So for a while there, I literally felt like rather I die. And Of course, when I started getting on treatment, I had this whole negative attitude and negative narrative with regards to ARVs. But being on treatment has literally changed my life. It has afforded me sort of a second chance at living a healthier life and a more fulfilled life, because now I know why I also need to get on treatment. Now I understand things like U equals U, which is undetectable, means untransmissible, which means that being undetectable means that I cannot be in a position to infect other people with HIV. It also means that I get to manage my HIV status a bit better. So being on treatment has really been beneficial for me, and I am quite glad that I'm at a point in my life where I'm just able to unapologetically adhere to my treatment without worrying about what anyone or any negative connotation or narrative about ARVs or HIV has to do with me. Thank you so much.
Divisola kakina Christine Mwinde na nilimo Z21 ipilenga kokwanika limo Z3 banifuma nikona mwa 2017 ndoka vikwalela ngani nosi mwanju ngenilira kandi ngenikwalera mwandu mato tisa ngane nina nganibona atanto yanga kwa kuwishimba muliane nisawa nisaba kuti batukafera bayinzimo akanisea ani mwatena kenafera chamwe ntokenelanga aitokela sento shimbanda ndende muliani ato nibizanga ba maki support group ataba ku join size mwa support group ya maki kuri utwele ntoloines yona nie ifele hakuli mwa maki lweza ngazenga tam activities zako yakoni kutwa lones unosi ukajoina ni waba aukiwe na unosi enzimo kiabanga tawa ins positive so akajoina maki support group mukaiza zenga tamukalanga bola mukaiza ngi mukafuma mateni kuna nzeba holisanga nge mapads etokulanga aitokulanga support group mba maki kwa toni isa kwa alikuwa kuinga muliani anto shimba muliani watoni black ngapele nina nosi watoni isanga wale shimbira muliani bani ngolela ento tanga watoni watela mashelenge ya transport amwe ento telanga kwano aito fita coronavirus noto lizezanga mafoni to shimba muliani wa 6 months noto lifanga muliani wa 6 months mkoya kuline muama ndosikelwa zama alozama sana kutinama face mask kapa kumaintain social distance kubani HIV hakimafelelezo yana wakona kuweza zengata ngena moni yeze psychosocial counseling kina mtu yakta vile ntazi kuna kona kuweza ze ona ngeni kashwa kanti kina nsapira ngewa bamo bapirezi wanitabezi kubani upiro boni bonifa.
For that video that you did. It was really heartwarming and brings the reality of what you go through on a day-to-day basis front and center for us as your providers and your peers and family in terms of what you face. I also want to thank the MAC AIDS team here at Siders for putting together that video. So Sadie, I'll hand it over to you to make some closing remarks and go through a couple of things before we break off for the poster session.
Okay, thank you so much. Yeah, that was a great video, and thank you so much to our next the video that came in after mine. That was also an interesting story, and it is important that we as adolescents, we as young people who are living with HIV, own our stories and own our narratives. They are our stories to change, and they are our narratives to change, and it is up to us how we want to be known. It is up to us to decide how we want this generation to be seen as. So we are greater than HIV. There is so much more we can still do. Life does not have to end after an HIV diagnosis. I'm so glad that we have such platforms and such workshops as this one, where literally it's just the main focus are young people who are living with HIV. Thank you so much to everyone who has joined. Thank you so much to our sponsorships. Thank you so much to my co-host and our speakers. Thank you so much to everyone. I think right now we are just going to go into the poster viewing. Thank you so much, everyone.
So before we go to the poster viewing, we have to remember our sponsors. This workshop would not have been possible without them, and the groups outside our sponsors who supported us through this. So specifically, GSK, Viv, and Gilead have made it possible, as well as Mylan, have made it possible for us to host this virtual workshop. As you know, without the support of our sponsors, both in direct funding or just technical support, we would not be able to have these workshops. Also, a shout out to the chair of this workshop, Linda Gale. Thank you so much for your guidance and support in getting us together to actually host this virtual workshop. And to the participants who keep joining the different sessions, let's keep joining. We still have ways to go, lots more to learn. So please do keep logging in, stay on for the poster session. Don't forget to take your selfies. Please tag us, tag eVirology, tag the Adolescent Workshop, post them on all your social media pages. We're tracking them, and we look forward to selecting the winners for the free registration for next year's workshop. So do also look out for my picture, because I'm looking to get free registration for the workshop next year. So I think with that, Sadie, we're going to break it off. Again, thanks to Caroline. Big shout out to you, Caroline, and all our oral presenters and our poster presenters. Bye-bye from Lusaka.
Thank you so much. Bye.